Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Otsuka America Pharmaceutical Inc. and Lundbeck.
Hello, I'm Dr. Anton Thorstensen, the William B. and Sheila Kohner Professor of Psychiatry, Neurology, Neuroscience, and Medicine, as well as Director of the Alzheimer's Disease Care Research and Education Program at the University of Rochester School of Medicine and Dentistry. Welcome to this program titled Translating Diagnostic Updates in Agitation in Alzheimer's Disease for the Primary Care Physician. Joining me today are George Grossberg, who is inaugural Henry and Amelia Nasrallah Endowed Professor and Director of the Division of Geriatric Psychiatry, Department of Psychiatry and Behavioral Neuroscience at St. Louis University School of Medicine, and Brendan Montano, who's in private practice at Montana Wellness and Director and Principal Investigator at CT Clinical Research in Cromwell, Connecticut. Welcome, George and Brendan. It's a pleasure. In this program, we will discuss first the finalized International Psychogeriatric Association definition of agitation in dementia. Then we will discuss how to apply this definition in primary care and geriatric care settings, including care algorithms and screeners clinicians can use. Then we will use cases to demonstrate how to apply the IPA definition. First, what is agitation? The International Psychogeriatric Association has published a final consensus definition with 4 criteria. First, the patient meets criteria for cognitive impairment or dementia. That can be any kind of dementia, such as Alzheimer's disease, frontotemporal dementia, Lewy body disease, vascular dementia, and also mild cognitive impairment or other cognitive disorder. In addition to that, the patient must exhibit at least one behavior that has associated emotional distress, is persistent and frequently present for at least 2 weeks, and the behavior is a change from their usual behavior. Types of behaviors that we see here are excessive motor activity, such as pacing, rocking, gesturing, restlessness, or repetitious mannerisms. It can also be verbal aggression, that is yelling, excessively loud voice, profanity, screaming, and shouting. Or it can be physical aggression, and that could be grabbing, shoving, pushing, kicking, scratching, slamming doors, and destroying property. What caregivers or care partners might often describe this as is short fuse. He's irritable. She's so easily upset, always angry. He's so restless. He's become so ornery. In addition to this, the behaviors have to be significant enough. They have to be severe enough to cause excess disability beyond the stage of cognitive impairment that the patient has. And the impairment can be in interpersonal relationships, other aspects of social functioning, or in functional abilities, such as the ability to perform or participate in daily activities. Finally, the behavior cannot be solely due to another cause, such as pre-existing psychiatric disorder, suboptimal care conditions, medical conditions, or the effect of a substance. Quite commonly, though, there are comorbidities, so this requires a little bit of a clinical judgment. I also want to make the point that agitation isn't the same as aggression. We can see agitation with verbal or physical aggression, But we can also see agitation without these types of aggression. So if I boil this down, we have a patient that has a cognitive disorder or dementia that has a new onset behavior that is distressing to the patient and to the care partner and is a change. It also needs to be severe enough to cause an excess disability and not solely due to other causes. Agitation is the third most common neuropsychiatric symptom among patients with cognitive disorders. The frequency can be quite different depending on the setting. For example, it might be different in early disease versus in late disease. It can also be different in institutional care settings, such as assisted living or skilled nursing facilities, and particularly if someone is in an acute care setting, such as admitted to a psychiatric unit. So the prevalence is incredibly high, can be up to 76% in certain settings. And it can also be frequently seen in patients with mild cognitive impairment due to Alzheimer's disease. And frankly, we can even see it in preclinical stages. But as a rule, we see agitation become more common as the disease wears on, reach peak in the late, moderate, and early severe stage, and then it can start to kind of fade again. So let's think about how to apply the IPA definition in primary care or geriatric care. George, what kinds of algorithms are available to us?
All right. Thank you, Anton. Let's talk a bit about what algorithms are out there. There are quite a few. This is one of them here, the DICE approach developed by Dr. Helen Kales, where the D stands for kind of describing the problem behavior, which is always a good idea, to obtain details, identify what's most distressing, looking for the context of when this is occurring, and also looking for underlying triggers, which is very, very important, things that might be modifiable. And then, of course, assessing the care partner's understanding of Alzheimer's disease and the fact that there may be neuropsychiatric symptoms that accompany that. So that's part of the description of the behavior. Investigating possible causes or underlying triggers, delirium and its many different causes, undiagnosed comorbid medical problems, pain, we'll talk about that some more, sleep disturbance, and boredom, I think, is an important one because we know that kind of a bored patient can often become an agitated or irritable patient. So the importance of having routine activities to keep patients busy. There may be factors within the care partner about how they're communicating with the patient, maybe inadvertently triggering some agitation, maybe increasing stress. And then, of course, environmental issues are also very, very important. Not to have too little or too much stimulation would be examples of that. And, of course, safety is always important. Once we've investigated the possible causes, obviously it's a good idea to create a plan for treatment or management. For the patient, we want to always address, physical concerns. For the care partner, we cannot say enough about education. Educating the care partner about basically what are the kinds of activities that your spouse or your loved one can do well. What are the kinds of things to avoid because they may cause frustration? But again, keeping them active is very, very important, and making sure that they have a safe environment and one that's not triggering some of the agitation symptoms. Once we've created a plan of management, obviously it's important to see if this plan is working. And if it's not, what adjustments maybe need to be made. And let's keep in mind that the plan always starts with the non-pharmacologic, but may eventually include a need for pharmacotherapy. So that's one approach. Another approach is one that we developed together with the Gerontologic Society of America, which we called a decision tree for healthcare providers. And it also has 4 components. The first component, which we think is very, very important, is always to ask. If you're seeing an Alzheimer's patient together with their care partner or family, at every visit, it's very important to ask about any changes in personality and behavior, any kind of concerns about challenging behaviors that are new or different than what we've seen previously. May not be a bad idea to use one of the quantifiable behavioral scales to quantify the frequency and the intensity or the severity of the behavior. And then, similar to what we just saw in Dr. Kales's approach, very important to conduct a differential diagnosis, to look for other contributors or other potential triggers or causes of agitated behavior. And in particular, things like delirium, which has many causes, including something as simple as a urinary tract infection, things like pain, depression, or psychotic symptoms that can also trigger agitated behaviors. I think, Anton, as you pointed out, it's important to try to apply the IPA criteria to make sure that we indeed have sufficient behavior, we have the quantity, the intensity, the impact. Those are all very important. And then to develop an approach, whether it's non-pharmacologic or pharmacologic. The IPA also has its own approach using their mnemonic, which is again fairly similar but more simple, investigating kind of the agitation episodes and quantifying and looking for impact, making sure that it's something different, it's impactful. P for planning interventions, and that would include the workup, would also look at the non-pharmacologic interventions, environmental modification, and so on, and then acting to implement the plan and making sure that, in fact, we're addressing the behavior and we're seeing good response or good results. Now, the IPA approach to agitation, just in greater detail, as far as the investigation, we want to make sure we understand the behavior and what the behavior is that's occurring. Does it meet criteria for IPA criteria for agitation? Does it occur at a specific time? Maybe it's sundowning only, or is it at all times during the day? Are there precipitating factors and, the intensity and how often it's occurring? Looking at patient characteristics. And of course, we want to always make sure that if we have acute behavior that may potentially result in harm, either inadvertently to the patient or others, then of course we have to act right away.
So, George, thank you for that overview. Brendan, what tools are there to help the busy clinician?
Well, after listening to both you and George, I wish I had the time that I could focus the way you fellows do on the patient. We are pressed for time in primary care. I'm concerned that because of that, we often overlook the most important things. We do the differential diagnosis, yes, because we're always looking at medical problems that can add to or worsen an already existing dementia. But when it comes to really screening carefully for changes, we haven't been very successful. And so today, I'm pleased to say there are some newer tools. The ones that are used in research are not available to the primary care doc because it just takes too much time. So things like the NPI, the Pittsburgh Agitation Scale, the Cohen-Mansfield Agitation Inventory, which is 29 behaviors, which have a graduation of either severe or not at all. And if you look at that, it means the score can vary, I think, up to 209. They're good for research, and they're good for assessment of interventions when we do make an intervention, but unfortunately too cumbersome for the usual primary care meeting, which is going to be anywhere from 7 to 11 minutes at most, in most cases. We have many practitioners seeing upwards of 30 to 35 patients in a day. So what we have now that I highly recommend is to screen the caregiver. And we have the ASK, the Agitation in Alzheimer's Screener for Caregivers, which is administered while the patient perhaps is still in the waiting room or in the exam room before you see them. And it's given to the caregiver. 7 questions, starting with repetitive behaviors and moving on to pacing and moving on to verbal aggression, cursing, swearing, raising your voice, screaming, resisting care, and then moving to physical aggression, throwing or hitting or breaking things and trying to hurt oneself or others. So this is very important, and especially for the caregivers, because what is keeping that patient from having to enter a tertiary care facility is whether or not they're able to manage without burning out, which invariably they do. But we can help. We can assist that caregiver with tools we have today. So I think it's important to assess these 7 behaviors. I think it's important also to know the second question, which is how do they negatively affect the individual's relationships, activities, or willingness to receive care? That's all so important, as we can intervene. So with that in mind, the ask for me is the only one that I'm using in my practice, other than doing the differential, making sure if they have diabetes, that their diabetes is in good control, that they're not getting hypoglycemic, going into delirium, that they are not having severe painful diabetic effects, peripheral neuropathy, etc. So if we're able to do those 2 things, take care of the primary problem and ask with the Ask Screener, the caregiver, right up front immediately, how well are you doing with these behaviors? Is it negatively affecting your loved one, or is it negatively affecting their care? And so that would be the screener that I would use.
Thanks, Brendan. Before we get to our case discussion, just a brief mention of ICD codes for AAD, or agitation in Alzheimer's disease. As you know, it's important for us to be able to code our visits, and these visits can be more complicated. So here are some codes that you might consider. So FO2, dementia and other diseases specified elsewhere. And the subcodes within that would be FO2.811, dementia of unspecified severity with agitation, FO2A11, dementia mild with agitation. If you substitute A for B, then dementia moderate with agitation, or B for C, that is FO2.C11, dementia severe with agitation. Also code the underlying condition first, which would be G30 for Alzheimer's disease. Now, let's talk about some cases. These cases are cases that each one of us has encountered in our clinical practice, and we want to apply the IPA consensus definition in recognizing and diagnosing agitation in Alzheimer's disease. Brendan, as a primary care provider, what have you seen?
Well, one particular patient who has been a recent patient of mine comes to mind. And he was a 75-year-old gentleman who had type 2 diabetes and went on to have to use insulin as well, developed into a type 1 basically, had loss of vision to the point where he was legally blind, and progressed on to where his wife would have to be with him continuously. So she would always come to the meetings, all the visits that we had, and we were having good visits until he began to have a progression of new onset of dementia. The dementia, because he was already being seen by a neurologist, was diagnosed as an Alzheimer's dementia, and it progressed to a point where he would get very angry and blurt out a lot of angry outbursts, to the point where his wife became actually frightened One day when she was shopping with him in a grocery store, he went into a display case and he got so riled and so angry that he took his cane and he smacked the display case, spilling it over. A lot of people noticed that and, of course, came to her aid and his aid. But immediately she was told by others, you can't live like this. You don't deserve to be treated like this, which just brought tears to her eyes because they had been inseparable for over 30 years. As it turned out, he got worse after he went in and had some cataract surgery, which did not do very much for his blindness and really just aggravated the entire situation to a point where the next time I saw him in the office, he was with his son, not with his loving wife. And that was, to me, a signal to call and find out what's going on because the son was not as forthcoming. She said she was frightened for her own health. She had quit her job. She had taken profound changes in her own life to care for her husband, but was getting to a point where she was depressed and not able to deal with the outcome of the Alzheimer's. So very shortly thereafter, he was admitted to a skilled nursing facility. If I look back at that case, for me, not immediately giving her a question about how are you doing, that would also include for me giving her a PHQ-9, considering her part of the patient caregiver unit, and should be immediately assessed at each and every visit and reassessed. So the impact on me was I better become more caregiver friendly. I better become more appreciative of the burden of this disease on the caregiver, because the only thing that's going to be keeping my patient, if possible, at home is good communication and that caregiver's well-being. And how does this fit? Well, it fits that definition that was given to us by Dr. Porsenstein. Yes, the man has dementia, cognitive impairment, criterion A, and B, excessive motor activity with physical aggression here. That was the second criteria. Did it cause disability? Absolutely. He was unable to get his care as usual from the people who loved him the most at home, and actually had to go to a nursing facility. We looked at his diabetes and his blindness, and we couldn't figure anything other than the Alzheimer's for the severe agitation that he was experiencing. So it was not attributable to another illness. This fit the IPA definition.
So, Brenton, thank you for that. And obviously, a significant change in his behavior, very distressing. Clearly, someone with progressive Alzheimer's disease. And the disease really took a turn for the worst, where basically there was so much distress within the system for him as well as for his family that he ended up in a higher level of care in a skilled nursing facility.
What kept them together for all those years was their wonderful appreciation of the conversations and the excitement they had being together. And of course, it totally was disrupted to a point of fear of one's own health.
Yeah, this couldn't illustrate any better the level of distress that we see and the impact it has both on patients and families.
I think, Brendan, the point you made too about when you see an Alzheimer's patient, you never have just one patient, you have at least two, the second one being the care partner, and the need to pay attention and to focus on them as well at every visit, I think is super important. So thank you for that.
So, George, how about a case from your rich clinical practice?
So this is a case from our practice. Mrs. Smith, an 84-year-old woman with advanced Alzheimer's disease, was in the special care unit, dementia unit of one of our teaching nursing homes. According to the charge nurse, for the past 2 to 3 weeks, She had had several episodes every day of kind of verbally agitated, kind of screaming behaviors, throwing her hands up, trying to strike out at the staff. Often these episodes occurred during what's called hands-on care, when they were toileting her or trying to change her, get her into pajamas or into clean clothing. The nurse reported that the primary care doctor had already checked a urine, checked a CMP. There wasn't anything in that regard, no evidence of head trauma. There were no new medications that were started. And obviously the behavior was really impacting both the patient as well as staff and others in the environment as far as their quality of life, and was getting hard for the staff to provide needed care for her. So we have a team. We have usually medical students, resident, fellow. We have called the entourage. We go to the teaching nursing home. As we went to see Mrs. Smith, she was actually in the dining area, but she was kind of slumped down in an easy chair. And I asked a couple of our medical students to very gently lift her up so that we could talk to her eye to eye. And as they started to very gently kind of move her up, we were able to see what the nurses were seeing. She started hollering and screaming and flailing her arms out and trying to strike out. But what we also found was, in that process, that her skirt lifted above her knees, exposing a swollen, tender, kind of warm-to-touch right knee. And of course, treatment was not with any tranquilizing drugs or behavior modification approaches in this case, but rather with anti-inflammatory medication, which resulted in resolution of her knee pain, as well as resolution of the verbally and physically agitated behavior. So this would be an example of a patient that did not basically meet all of the IPA criteria, but using the investigational criteria that the IPA developed, we were able to find an appropriate trigger, which in this case was pain.
And George, you covered very clearly and concisely the different kind of criteria to work things up, which really focused on a similar underlying theme, which is to carefully evaluate what is going on and understanding if there are some other causes that are predominantly responsible for the behaviors. And here it was pain. What a surprise. And the fact that this could go without being noticed, and that it was you and your team that, in a way, accidentally uncovered what was going on, and how important it was for her quality of life. Very clearly showing that this did not meet the fourth criteria for the IPA definition of agitation.
Yeah, I think that's fascinating, and it brings to light to me that it is truly a team approach with all of our patients, and particularly our Alzheimer's patients, especially when they're in a facility. So being able to question the nurse's aide, the nurse, charge nurse perhaps, and really get a good feeling for the entire gestalt of the patient in this case was very important.
So let me follow up with a case of my own. This is Tim, who is a younger gentleman, 69-year-old man who was diagnosed with Alzheimer's disease a year ago. He was seen by me in my practice. And I had a follow-up visit scheduled, but his wife called my office and asked for him to be seen early. What had happened is that there had been a change. His mood was more labile. He was choking up easily. Intermittently, he said that he felt down, that he was blue. But usually he attributed this to fear and frustration over what was happening to him. He was very aware of his diminishing faculties, that his cognition wasn't as good. He admitted to anxiety and restlessness. He worried more about being the victim of theft, and he routinely locked his doors and checked on that. His wife reported that she would often find him pacing around the house. He was much more frustrated and irritable, especially if something was outside his routine. He struggled more with decision-making, which was a change for him, and had trouble with tasks that used to come easily. He would get restive and upset when his wife offered to help him. He would angrily storm out, pace in the yard until he calmed down. His wife said he's ornery and he's a short fuse. That is so different for him. The behaviors were now happening a few times every week. They had been increasing steadily in frequency and also increasing in intensity. At the same time, there was no prominent verbal agitation and definitely no physical aggression here. His wife reported that when I asked her about what impact does this have on you, that the behaviors often bring her to tears, that the symptoms have been worsening, and because of this, she's not taking him out as much, not visiting the children, not spending as much time with the grandchildren, because she doesn't want them to see him like this. So if we look at how this case fits the IPA criteria, then the patient had a well-established diagnosis of Alzheimer's disease. He was showing signs of distress. Could we say that he was depressed? No, he wasn't hopeless. He wasn't helpless. These feelings were fairly fleeting and always triggered by something where he was facing his limitations. The behaviors had persisted more than 2 weeks. They'd worsened actually over the past 2 months, and they were causing marked distress not only to the patient, but also to his wife. It was impacting his social functioning. And pretty clearly, when we looked at things, there were no apparent acute medical contributors to the behaviors. So fairly consistent with meeting criteria for the IPA definition of agitation in Alzheimer's disease, and kind of a non-aggressive type, so no prominent physical aggression or verbal aggression.
I was going to say, Anton, that's an interesting case. I would definitely think about depression as a possible trigger, agitated depression. And we know that depression in Alzheimer's disease and dementias in general doesn't always present the same as it does in cognitively intact older adults. And also, I'm a little concerned about suspiciousness or paranoia with him kind of checking and locking the doors. And could psychosis be contributing as an underlying trigger in your case? I think it's a great case.
And thanks, George. That's exactly some of the things that we considered. And basically, I did a thoughtful and careful assessment of how persistent the depressive features were and how predominant the psychotic features were. And at the end of that assessment, I saw those more as kind of comorbid conditions, definitely something to keep in mind as I selected treatment, be that the non-pharmacological approach in validating what was going on and kind of overall behavioral management, as well as the pharmacological approach going forward. To recap our program here today, we talked about the International Psychogeriatric Association diagnostic criteria for agitation in Alzheimer's disease, and want to just highlight again the presence of a cognitive impairment, nuanced behavior that is of significant frequency and is distressing to those around you, as well as doing a careful workup for underlying contributors and eliciting that this change is not solely due to another underlying medical condition or psychiatric condition or the effect of a substance. Are there any final comments from you two before we thank our audience today?
I just think it's so important to have an early on approach to the caregiver, as George also reinforced what I had said earlier. I think giving the caregiver a PHQ-9 is a good idea. We don't really talk about that very often, but they get depressed. And when they're depressed, they're limited in how much they're able to give to the loved ones. So giving them a PHQ-9 and an ask would be my approach right up front.
Yeah, I would agree with that. And the importance of every visit, again, asking about changes in behavior or personality, and then using that as an opportunity to also look at the care partner and see what their needs are.
George, Brendan, thank you for this wonderful discussion. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.